CataractCoach.com. Cataract surgery with asteroid hyalosis. Can this patient do well with a multifocal lens? That's a good question. So we see all these opacities, which are calcifications in the vitreous body. And this can be in one eye in patients. It can be in both eyes. It can be asymmetric. And it can be a variable amount. Some patients have a lot of these refractile bodies. Some have very few. And the patients don't notice these opacities. They've been there the entire life of the patient. And so the patient never sees these. The incidence of this is somewhere between 1 and 2% in the general population. A study out of UCLA by a former resident at Monty Fozzi found that about a 2% incidence of asteroid hyalosis in about 10,000 patients examined in an autopsy population. So the case for us is going to be relatively routine. We'll do our straightforward cataract surgery. For me, that's going to be a phaco chop. And then at the end, we have a choice of what lens to put in the eye. With these refractile bodies, these calcifications in the vitreous, it makes it very easy to see just how much vitreous movement there is during a routine cataract surgery. It makes it very easy to mark and see how much vitreous movement we have. You know, when I had this patient in the clinic and we took a photo of the retinal fundus, you can see just how many of these refractile bodies there are. And though the patient doesn't notice them, undoubtedly, these are going to have effect on the contrast that the patient sees. These are refractile bodies that are going to scatter light. And that, to me, means we're probably best off in putting in a monofocal lens for this patient. Now, the question was posed, can you just put in the multifocal, and if the patient doesn't do well, then do a pars plana vitrectomy and remove all the vitreous? I suppose that's an option as well. But for me, the best number of surgeries for the patient is the fewest number of surgeries. And I think this patient will do very well with a monofocal IOL, a target of about plano, and then using reading glasses for up close. So there's the chop. We have split the nucleus into two halves. We'll remove this and finish up the case. Let's fast forward to the end. Here we can see as we remove the cortex, there's a lot of refractile bodies, a lot of these calcifications there. Even more prominent now when we have the cataract out of the eye. The patient also has a PVD in the back, which you can see a shadow of there. And so we're going to put in a monofocal lens here. I think that's the best option for the patient. We're not going to split any light. We're not going to decrease contrast with a monofocal lens. If we put a multifocal lens in, and there's a picture of one here in the corner, those rings split the light, and you can't cheat physics. You're going to have a consequence, and that consequence is going to be a decreased amount of contrast. And I think with these asteroid hyalosis and these refractile calcium bodies, those are also going to affect the contrast level that the patient sees. And I think those two together would not be a great combination. And that's why we're choosing here just to use the monofocal lens, aim for a targeted plano. I think the patient will do best like this. In the post-op period, the patient did beautifully and achieved a great uncorrected visual outcome, hit the target of plano. We did the other eye that had a very similar degree of asteroid hyalosis, and the patient did well there too. And the patient was very happy with the surgery, and we were happy, and we didn't take a chance. Here we are at the end of the case, IOL in the bag, good overlap of the rexes, and you can see a lot of these refractile bodies from the asteroid. Check out CataractCoach.com. It's our teaching website. There's a lot more material on Cataract Coach than you'll find here on YouTube. Plus, it's very easy to search by categories. Check it out. I think you'll like it.